We are going to talk about agents used to treat eye disorders in this chapter. These medications are going to be divided into a couple of different groups. The first are going to be medications that treat glaucoma, so these anti-glaucoma agents. They are going to address the intraocular pressure that increases in glaucoma. This is something that is controlled to some degree by the autonomic nervous system. So you'll see that the ANS drugs are going to play in this pretty heavily. There's anti-infectives, anti-inflammatories, and then artificial tears and lubricants. So as I mentioned, we're going to start out with drugs that will affect the pressure inside of the eye. And one of the ways the body is able to alter this intraocular pressure is by altering the size of the pupil. You might know that in sympathetic outflow, the size of the pupil increases, so the diameter increases. And that is to let in additional light in the instance that we were faced with some sort of threat. Whereas in parasympathetic outflow, when you're in rest and digest, we usually have a basal tone where there is a partially constricted pupillary area, which can be a decreased diameter, even more so when we emphasize this parasympathetic input. So when we stimulate parasympathetic input. So sympathetic increases pupil diameter, where parasympathetic decreases pupil diameter. And when we're thinking about this area, this is going to alter two different muscle groups, a sphincter group, which is going to contract in a circle, and then this dilator group. All right, so as I mentioned, we've got sympathetic activation, and when we have sympathetic activation, we are going to get changes to the pupil size, which increase the pupil size. And the way that that is controlled is by altering the tension of the ligaments that suspend the lens within the eye. And those ligaments are connected to a muscle called the ciliary muscle. I want you to imagine the lens suspended from these ligaments in a similar way that you would think of a trampoline. So if we look at a trampoline suspended by the springs on the frame, that looks not like a sun at all. Looks like a trampoline on a frame. The springs hold that trampoline taut. They hold it flat. And we can think of that as a partial contraction. The trampoline is held in this contracted state so that you can bounce on it and not fall through. So this is the way that the lens is suspended within the eye. When we have these ciliary muscles really in their relaxed state, what they do is hold these ligaments taut so that the lens is held like that trampoline, nice and flat. So when you think sympathetic, we're going to think of ciliary muscle relaxation. And that relaxation allows the ligaments to be in their natural position, allowing the lens to be flat and to be held taut in the case of its natural seating. And that's going to increase, again, the diameter of the pupil, letting more light in. So sympathetic activation, flat lens, relaxed ciliary muscle. Whereas in the parasympathetic system, that's more associated with pinpoint size pupils, so miosis rather than these large pupils that we call mydriasis. In parasympathetic activation, we get the fattening up or the bulging of the lens. And that occurs because we get contraction of the ciliary muscles. And they contract as a sphincter does in a circular way, so that when they contract almost in this swirling type of way, it causes these ligaments to loosen up. So the lens is no longer held nice and flat. It kind of is allowed some slack because the ligaments have loosened, they've slackened. And when the slack develops, the lens is able to fatten up, essentially. So parasympathetic activation is really going to contract these ciliary muscles that contract in this circular motion as sphincters tend to do, which will loosen up those ligaments and allow the lens to get fat and to bulge. And when we have this contraction, again, not only is that going to make the lens nice and fat, but when we're looking at the lens here, when these muscles are contracting, they're going to make the iris appear larger, and that muscle is going to overtake that inner portion of the front of the eye, so that the pupil appears smaller. So the iris gets bigger because underneath it is muscle, and the pupil gets smaller. So contraction of ciliary muscles, reduction in size of pupil diameter, and a nice big fat lens. So no surprise, we are going to utilize these existing things in the body, these existing mechanisms that are going to either flatten in sympathetic mode and make the pupil really big, or going to fatten up the lens and make the pupil really small. And we'll call those mydradix and miotics. And when we're talking about these, here's our normal untreated eye. We call mydriasis the dilation of the pupil. And mydriasis not only refers to a large pupil, but it also is a term that's used to describe dry eye, because when the pupil is that large, it's going to physically obstruct these outflow pathways so that we don't have eyes that are as lubricated as normal. So if you've ever had your eyes dilated for an eye exam, not only is it really uncomfortable to look at light in any way because there's a lot being let in through that really dilated pupil, but in the pupil dilating so much, we now cut off our lacrimal supply to the eye. So we're not getting good outflow of fluid. Whereas with drugs that are parasympathetic in nature, we're activating this contraction of the ciliary muscles, decreasing the size of the pupil. And when we decrease the size of the pupil, again, anatomically, what we're doing is opening up areas, allowing for the outflow of fluid. So that fluid, if we're thinking about the aqueous humor inside of the eyes, so in addition to just tears, so we're getting some manipulation to these lacrimal glands, but also we have the outflow of aqueous humor from the inside of the eye that's going to help regulate pressure. So we can utilize substances that can either dilate eyes and take advantage of the sympathetic system, or to constrict pupils and take advantage of the parasympathetic system. We can see an animation of why this works so well here. So if we're looking inside of the eye, we have our lens, we have the iris, our singular iris here, so our muscular portion. And we have, again, the iris is the colored portion, so that's the colored portion, and the hole through which light moves to the lens that is not the colored portion. In the center of it is the pupil. All right, at this point in the back of the eye, in this anterior segment of the eye, we have the development of aqueous humor. And that aqueous humor is going to come out and flow out where the lens is. And it should empty out into this fun little canal and then out through the conjunctiva. If there is any abnormality that doesn't allow an open angle there, that doesn't allow good flow of fluid, that fluid will back up, and where it backs up is in the eye. So here is an open drainage channel in a nice healthy eye. The fluid is being produced, it's flowing out, behind the lens and then draining, and everything is great. However, if there is a blocked channel, the fluid cannot exit out of these channels around the lens, which means we're going to have a buildup of fluid and a buildup in pressure. And why that is so dangerous is not only do we have a blood supply around the outside of the eye, we have sensory receptors there. All of those sensory receptors converge to make the optic nerve. And also at the back of the eye, that's where all of your photoreceptors are that let you see in the dark, let you see in the light. So if that pressure goes up inside of the eye, then we can have the physical destruction due to pressure of not only these specialized photoreceptors, then also you can have damage to the actual optic nerve, which will unfortunately permanently damage vision in some cases. Because we have the magical physiology of the body already existing with the sympathetic and parasympathetic nervous system already having their influence over pupil size and dilation and constriction and then the opening of these outflow channels, we can utilize those existing systems by solving, to some degree, the problem of glaucoma. So we'll first talk about cholinergic drugs, and they are named that because they primarily affect acetylcholine. And we'll get into specifics on the next slide, but we can divide cholinergic drugs up into two different things, two different big categories. Either they're cholinergic stimulants, so they're going to increase acetylcholine activity at the level of the synapse, or anticholinergic, which means they will decrease synaptic activity of acetylcholine. To remind you, if you've ever forgotten, which why would you? It's such a glorious system. We've got the sympathetic nervous system and we've got the parasympathetic nervous system. Both of these systems work in these two neuron chain systems, meaning we have an originating neuron, which we call the preganglionic neuron, and then we have a postganglionic neuron. I don't know why I wrote that there. It says preganglionic right there. I just got carried away and I kind of liked it. All right, so we've got preganglionic and postganglionic, and what that is referring to is an anatomic location of the ganglia. And a ganglia is just a group of cell bodies that all does the same job. They all hang out together, and for these neurons, they provide a location for them to synapse with one another. So in the sympathetic system, the preganglionic neuron synapses with the postganglionic neuron at the level of this paravertebral ganglia called the sympathetic chain ganglia. And the neuron, the preganglionic neuron, releases acetylcholine. And that acetylcholine binds to nicotinic type receptors on the postganglionic neuron. And in the sympathetic system, where we have a difference, mainly in neurotransmitter, is at the level of the postganglionic neuron, which spits out norepinephrine, NE, norepinephrine. And that norepinephrine binds to alpha receptors and beta receptors that are out in the tissues. Whereas with the parasympathetic nervous system, we have a craniosacral type of system here, and the ganglia themselves are out in the tissues. So the preganglionic neuron is relatively long in an anatomical sense. However, we still have the conservation of what the preganglionic neuron does. In the parasympathetic also, we have the release of acetylcholine from the preganglionic neuron that also binds to nicotinic type receptors that exist on the postganglionic neuron. In response to that, the postganglionic neuron releases acetylcholine. And at the level of the tissues, the type of acetylcholine receptor is called a muscarinic type receptor. So if we're thinking mainly of the final products of these pathways, we've got norepinephrine as a final product of sympathetic, and we have acetylcholine as a final product of the parasympathetic. However, in pharmacology, you're going to see weird side effects for things, especially these types of drugs. And you might think, why does it do that? Like, it's a norepinephrine drug, or why does it do that? It's a cholinergic. The reason you'll see weird things, not the only reason, but one of them, is that even though in the sympathetic system, what we're trying to do is alter norepinephrine release, in order to get norepinephrine release, we still need acetylcholine to be released into the synapse to drive norepinephrine release. So we still have the involvement in acetylcholine in the sympathetic system. Just keep that in mind. And that might help you when you're trying to wrap your head around these weird side effects you'll see with sympathetic and cholinergic drugs. All right, so when we're thinking about cholinergic medications, again, cholinergic drugs, they increase the activity of acetylcholine at the level of the synapse. So cholinergic stimulants, they can either be direct or indirect. And that's pretty straightforward in that a direct cholinergic stimulant looks like acetylcholine. It looks like acetylcholine, it acts like acetylcholine. So it does everything that acetylcholine does. It is the same shape, relatively. It can bind to the same receptor site, and it mimics perfectly the action of acetylcholine because it looks just like it. So it can bind to muscarinic type receptors, it can bind to nicotinic type receptors, and it stimulates them in an agonist way you would see acetylcholine do. The only difference is that we call this an exogenous agonist, an exogenous, meaning it's created outside of the body, whereas acetylcholine is an endogenous agonist. It's created inside of the body, and it has the perfect fit for these receptors. So, surprise, surprise, a cholinergic stimulant means that it would increase everything parasympathetic. And also drugs work, remember, in a dose-dependent fashion, meaning the more you take of something, the greater the effects that they have. So think about a drug that really increases your salivation, your digestion. So when you start to think of that, that's things like sarin gas, right? That's organophosphates. They're things that are toxic when you take them. So not all of them are super safe. Very few of them are safe enough to use in a clinical type of environment. So we want to focus on drugs that are given in a peripheral way, so they're not given centrally, the more specific at the level of the receptor type. Not only the receptor type, but like the specific subunit of the receptor. So this is an alpha subunit of a nicotinic type cholinergic receptor. The more specific something is, the more expensive it is. However, the least amount of side effects are seen with a high specificity drug. So direct stimulants, they act like acetylcholine because they look just like acetylcholine. They bind everywhere it can, so they mimic the exact response. One of them on the market, we're talking about glaucoma. So this is an anti-glaucoma agent. It's called Carbachol, and it's sold in many different formulations. There's Carbistat, there's Carboctic, there's Myostat. And this can be given in a topical preparation. And generally when drugs for glaucoma are given topically, they're not just drops, they're what we call gel-forming drops. So they form this thicker viscid liquid when they're applied. They're also available, like in this picture, you can get an injectable of this, meaning that you can inject it directly into the eyeball. Just a little note, whenever you're injecting something inside of the eye, you're taking a little bit of a risk in that you will increase the pressure or decrease the pressure if you hit something wrong. If you decrease the pressure too much, you'll detach the retina. If you increase the pressure too much, you'll crush the retina and possibly the optic nerve. So there's a lot of specificity involved with this. But the way that these cholinergic stimulants work is that they're going to mimic acetylcholine. So in the way that acetylcholine would drive parasympathetic activity in the eye, that would be this contraction of the ciliary muscles, a loosening then of the lens, getting nice and fat, and then also the pupil size decreasing. Really, whenever we decrease the pupil size, we're increasing the ability of fluid to leave the eye. All right, we also have indirectly acting acetylcholine stimulants, and we call them indirect because they are not true agonists for acetylcholine receptors. Instead, they're going to increase the activity of acetylcholine by doing something that is going to prolong the amount of time acetylcholine is out and about in the synapse. So they're not just drugs that look like acetylcholine and bind to muscarinic receptors. I don't mean to make them sound boring. They're not. But what they do is affect things like the enzymes that break down acetylcholine. So if you attack the enzyme that breaks down acetylcholine, then you're not going to have acetylcholine broken down. So you can see this being targeted, the enzyme that breaks down acetylcholine, great name, acetylcholine esterase. This enzyme breaks down acetylcholine into its two component parts, acetate and choline. What you're looking at in this picture are those two pieces being sucked back up into the neuron because your neuron loves regifting. Why should it have to make something again when it can just put something back in a vesicle and release it like it's brand new? So we can give drugs that target this enzyme, and if the enzyme's not active, then we don't get the breakdown of acetylcholine. The longer acetylcholine is out in the synapse, the more likelihood it has of binding to acetylcholine receptors and then activating a cell. So we call these cholinesterase inhibitors or anticholinesterase drugs. So they increase acetylcholine, but in an indirect way. So this is the way that they work. So in this picture, we see an enzyme. It's acetylcholinesterase. And remember, its job is to take acetylcholine and cut it up into pieces and then get sucked back up into the cell. Because normally acetylcholine would be doing stuff like binding to its receptor, opening up channels and letting excitatory ions and all kinds of stuff, wreaking havoc on the body. So wherever you find acetylcholine receptors, like on the heart, for example, wherever you find them, you'll also find acetylcholinesterase. That's because we don't want acetylcholine like hanging around most of the time, like continuing to bind to its receptors, because that would do things like make the heart continually beat, and we don't necessarily want that. We want it broken down. So wherever you find a receptor, you're going to find the enzyme for it. All right, so in this picture, we have a drug, neostigmine, that is an indirect acetylcholine increasing drug. And we can see that essentially what it does is sit in the receptor site on this enzyme, acetylcholinesterase, ACE, acetylcholinesterase. And in this case, acetylcholine can't bind at the level of the enzyme. If it can't bind, we can't break it down into acetate and choline. That means that the acetylcholine is out here in the synapse, free to bind to muscarinic receptors and free to bind to nicotinic receptors. So this is an indirect way of increasing acetylcholine by targeting the enzyme that would break it down normally. So introducing those drugs, I showed you one earlier. We also have, so we said neostigmine, then which I'll mention on the next slide, but then when we're talking about these direct acting drugs, We have pilocarpine, myostat. So these are our direct ones that look like acetylcholine, bind to its receptors, and they do acetylcholine things like constrict the pupil by contracting that ciliary muscle. Again, whenever we constrict the pupil, we're opening up those channels, allowing the outflow of aqueous humor. And these drugs also decrease the production of aqueous humor, meaning there's a lower likelihood of physical damage to the eye due to too much fluid building up in it, and then damage to the receptor sites, to the optic nerve, and to the blood flow. ROA, route of administration. As I mentioned, these can be given as drops that form gels to become thicker and stay on the eye, or they can be injected directly intraocular ways. Fun. Adverse effects, brow pain, local irritation, and blurred vision, which is coming from alterations in the pupil size. All right, and then some examples of our indirect acting acetylcholine stimulants that target acetylcholinesterase. We've got physostigmine that is not only used for glaucoma, but if, like I mentioned, sarin gas and organophosphates, which are things you spray on crops to get rid of bugs and stuff. If you come into contact with them, you get poisoning. You get too much parasympathetic activity. You start hypersalivating, and then eventually the heart stops. So what do? Well, you can reverse that by giving a medication that would reverse acetylcholine activity. Physostigmine can be given by injection. There's also demicarium, sold as Humersol. That's another injection, and a side effect of that, unsurprisingly, is retinal detachment due to changes of the intraocular pressure. And that fluid is there really to hold everything against the back of the eye. So once we start messing with it, we now have that risk of damage to the retina or detachment of the retina. So because those medications we just mentioned were acetylcholine stimulants, we will see that the side effects of those medications will be essentially too much parasympathetic activity. So this is opposite. So I put this here so you remember. We are generally pretty familiar with what we call anticholinergic side effects. So those are medications that would decrease acetylcholine activity. And what those do is decrease parasympathetic nervous system activity. And the parasympathetic nervous system does things like make saliva, perfuse your brain appropriately, rest and digest. So you start moving stuff through the GI tract. It causes the bladder to go back to its basal tone so it can fill and then empty. So anticholinergic side effects are dry mouth, constipation, urinary retention, confusion. So you'll see the opposite for these drugs. You'll see that there's going to be an opposite to that. So GI distress is something that can happen because the parasympathetic is rest and digest. It's going to kick all of that up. So there's going to be more gastric activity, possible nausea and vomiting, more movement along the small and large intestines, which can cause, one of my favorite things is called peristaltic rush. So usually you have a couple of really large mass movements of the colon throughout the day, and peristaltic rush is when there's just one really big wave of peristalsis. That's a colon, in case you can't tell. One really big, large, not a question mark, maybe a question mark, wave of peristalsis, which just empties out everything from the colon all at once. So that's some diarrhea. Fun, right? Increased salivation, bronchoconstriction, because those are beta-2 receptors there in the bronchi. That's obviously spelled wrong. But when we activate beta-2 with norepinephrine, we get bronchodilation. So parasympathetic brings it back to vagal tone. But if we're kicking it up past our homeostatic rest and digest, then we'll start to see constriction. Same thing with the heart rate. The parasympathetic should bring a fast heart rate back to resting, but if we overactivate it, we can get a slow heart rate or bradycardia. And then you can see alterations to the blood flow. So if parasympathetic, again, it's rest and digest. If we're really kicking that up, that means we're going to divert the blood flow to places like the colon, like the stomach, and that's going to change the perfusion of the blood vessels at the level of the skin. So that might make you really cold, it might make you hot. So it's going to change and alter the body temperature and then lead to things like sweating and flushing. So side effects of cholinergic stimulant drugs are going to be side effects that are associated with too high of an activity of the parasympathetic nervous system. All right, on the other end of drugs for glaucoma, we might want to give medications to do things like check the eye. That's what you see here. If we want to look all the way back at the retina and make sure everything looks nice and healthy, then we're going to have to dilate the eye. And that's done with drugs we call mydriatics, which are going to give you mydriasis. That's that term I mentioned before, mydriasis. That's the development of dry eyes and large pupils. And remember, the eyes are dry because the larger the pupil is, the worse of an outflow of fluid we have. And also, we're going to manually obstruct some of these lacrimal areas because the eyeball will bulge. Okay. So the way that these drugs work are prototypical is called atropine, which you've probably heard of. It's used for almost everything. It's like the catch-all for all of these things. So when you want to dilate an eye, you can give atropine just through eye drops, although you can give atropine really in any way you can think of. But what it does is paralyze essentially the ciliary muscles and the dilator muscles. And that will lead to extreme pupil dilation and what we call paralysis of accommodation. There's another M in there. Finding all these typos, man. Accommodation is the eye's ability to see up close and then far away. It accommodates with changes to the lens size and pupil size for far versus near vision. Atropine and drugs like it, they fix the pupil size, which is then associated with a fixed lens size. So you cannot accommodate to near versus far vision. It's paralyzed for that time. So again, it's used a lot for intraocular examinations. And if you want dry eyes or a large pupil pre or post-op, you can induce it with atropine. The word vision should be here. It's cut off, but side effects are stinging because you have a lot of pain receptors on this level of the conjunctiva. And the more pupil you have there, because the iris is smaller, is going to really stimulate those pain receptors. They become hyper responsive. Also, when the pupil's that large, it's going to obscure vision. So you'll see blurry vision with these. Okay, so drugs like atropine, we refer to them as anticholinergic. So they are blocking the activity of acetylcholine. So acetylcholine would bind to its receptor and do things that acetylcholine does. Drugs like atropine, they block the receptor site so that we don't get acetylcholine binding and acetylcholine activity. So these bind reversibly, which means they can, like atropine can pop on and then go off again. It doesn't destroy anything and it doesn't stay there permanently. It binds to it. It's just an antagonist. It's a competitive antagonist, meaning it competes with acetylcholine for this binding spot. It doesn't agonize it. It's an antagonist, so it just binds here and it sits there and prevents acetylcholine from binding. And if it's anticholinergic, it means it can block either one of the acetylcholine receptors, which can either be muscarinic, which are the ones out in the tissues generally, or they can block nicotinic, which are the receptors mainly on nerve cells. Here's another schematic showing you how this works. Look how nice. Here's a muscarinic type 2 receptor. Remember, muscarinic are usually in the tissues. Here's acetylcholine. Oh, this person spelled it wrong too. Ha, I'm not the only one making typos today, bros. All right, so acetylcholine's trying to bind here, but it has a competitor, and that competitor is atropine. And atropine is an antagonist, so it'll just sit right here and prevent acetylcholine from binding. When you don't have acetylcholine activity, then you don't have parasympathetic activity. All right, so as I mentioned, atropine is our prototypical drug. Atropine is a natural substance. It comes from the belladonna plant. Belladonna means beautiful lady. And when you take these berries from the belladonna plant and grind them up, then you get atropine. Fun little story. Looking at this pupil here. Back in the day, you could buy eye drops just called belladonna eye drops, because not only do we get pupil dilation when we're in sympathetic outflow, we also get them when we are in love, when we're happy, when we're excited. When you're interested in something someone is saying, your pupils get bigger, so you appear to be interested in whatever they're talking about. So women, when they wanted to get a husband out of one of their many male suitors, obviously they have so many choices because they are awesome bosses back in the day. And I know that they were awesome bosses because they cheated the system by going to the store and bought belladonna eye drops so that when they went on their dates, no matter what their suitor was talking about, they had really large dilated pupils, which made it seem as though they were interested in what they were saying and they were attracted to them. Isn't that beautiful? So that's belladonna. Today, we use that for eye exams and really anything that you need to have a neuromuscular blockade against. It reverses all types of neuromuscular medications, and it can be given really, again, any way you can think of, in injection, in drops, like right here. That's our prototypical drug, atropine from the belladonna plant. Look at this beautiful table. Here is a table showing you these drugs, cholinergic drugs. They're broken up into their nicotinic and muscarinic subtypes. We've got our endogenous ligand that naturally binds to those receptors. We've got our acetylcholinesterase inhibitors, organophosphates I keep mentioning. Those are irreversible. Those are your things you spray on crops to kill insects or insecticides. And then we've got neostigmine, which we've mentioned. We've got our agonists, so like nicotine at the level of the nicotinic, and then muscarine at the muscarinic, and then bethanechol, which is mainly used in urinary interventions. And then we've got our blockers. So we talked about atropine because we're talking about glaucoma. And there's also a drug called scopolamine, which is used not only for motion sickness, but it's also used in a lot of different ways now. I'm an addiction scientist, and we've started to use scopolamine for treating a lot of substance use disorders. All right, that's what I gotta say about that. Other medications that we can use to target glaucoma. Again, because we've got the sympathetic and parasympathetic systems, we can take advantage of the receptor subtypes. And so far, we've talked about acetylcholine, but don't forget, we've also got sympathetic and the norepinephrine that it releases. You might know that beta blockers all end in olol. So we can see, without even seeing this drug name before, timolol, we can tell that that's a beta blocker. And beta blockers work to block beta receptors at the level of the ciliary muscle. All right, so here's the deal. Beta 2 receptors, it's an even number, which means that normally if you stimulate it, you're going to have relaxation. So these like timolol, what it will do is block those. And if it's normally going to relax, if we block it, then we're going to get contraction. That will lead to the pupil becoming really small, increasing the outflow of fluid and decreasing the pressure or tension inside of the eye. So beta blockers are a really nice option for glaucoma because they're pretty specific to these beta 2 receptors. And they have actually, if you read the studies, pretty outcomes associated with them. All right, other things that are good. All right, so medications besides timolol that are given as eye drops: betaxolol, cartiolol, levobunolol, metopropanolol. Again, eye drops or these gel-forming liquids. And beta blockers work similarly to these cholinergic medications in that they decrease aqueous humor production in addition to altering the pupil size and then the outflow of fluid. However, when you look at the use of these, we have beta 2 receptors in the lungs and in the heart, and in females at the level of the uterus. So we're not being super specific, even if we are giving them as an eye drop. So we still don't want to use them in things like respiratory disorders, like asthma, because if somebody's really sensitive to these drugs, we can see respiratory issues, trouble breathing. We can see slow heart rates because we're altering norepinephrine activity, abnormal rates, so a loss of rhythm, low blood pressure. If the heart beat goes low, then the pressure will go low. And sexual dysfunction, we see this present as erectile dysfunction in men. And essentially what that's saying is that the blood flow can't be maintained to the penis because of a lack of tension in that blood flow. So the vessels don't have adequate tension to be able to dilate and stay dilated to sustain an erection. So that's always going to be a side effect with medications that are going to alter beta activity in a more systemic way. Again, these are not saying that everybody who takes these eye drops get that, but adverse effects means that it is a possibility of happening. Like all beta blockers, we really want to avoid giving them to anyone with a history of asthma or any other respiratory disorder, because we're going to get the blocking of beta 2, which normally relax bronchi. So if we're blocking that, we're going to get constriction. All right, we also have alpha adrenergic agonists like aproclonidin, brimonidine. These are given as eye drops and gel-forming liquids. And just like we had our beta adrenergic receptors, we have alpha adrenergic receptors. So these are things that can be given in place of a beta blocker because we're not going to have as much of a respiratory issue. So if we don't want to give a cholinergic medication, but we're worried about respiratory issues, you can give an alpha adrenergic medication. They're given in these drops the same way. So they're not like the cholinergic ones where we're giving, injections inside of the eye. So they're given topically. They do decrease aqueous humor production, and through altering the size of the pupil, they increase outflow. Adverse xerostomia, ocular hyperemia, ocular irritation, headache, fatigue, and possible allergy. If a patient has an allergy, it generally, because of the way hypersensitivities get work, they get worse with each administration. So you'd want to discontinue use. It is not recommended in cardiovascular issues or with hypertension, but a benefit is that it really does alter the aqueous humor production. Like most of the medications, they do advertise that, but clinical trials show that this is a really significant decrease in aqueous humor production. All right, ending with some other things. So here's your rule. If it ends in cane, it means it comes from cocaine, and cocaine is our original local anesthetic. So things like ponticaine, tetracaine, if it ends in cane, metricaine, that means that it's a local anesthetic. Let's say that somebody got something in their eye. Let's draw an eye. Here's an eye, and here's something in it. Ah, crap. Maybe it is stuck there. Maybe it scratched the eye, and we don't know. Well, how are we going to get it out? Or how are we going to dye that cornea to see if it's lacerated? The answer is giving a topical anesthetic in a drop to numb the eye temporarily, to either remove a foreign body or to apply the dye to the surface of the eye to see if it stains in an area where it's been lacerated. My doctor always called these ice drops, which is a fun name, because when you have an anesthetic, it really feels like something is cold there. So your eyes immediately feel better because they're probably hurting before you had that tetracaine on there. But they always say, don't touch your eyes. Like, even if your eyes get really itchy because your pupil size is off, don't itch them. Well, here's the reason why. Your eye's now numb. You can't feel anything. And remember, if you even press on your eye, you're going to fire your rods and cones. If you press on your eyeball right now, you're going to start to see flashes in different colors. That's because you've stimulated your photoreceptors. So if you can't feel your eye and you start rubbing on it, you can cause quite a bit of damage. So you just have to be sure, even though it's an irritating substance, all cane substances burn, all anesthetics burn, and then eventually they wear off and you get numbing. But make sure nobody rubs their eyes too much afterwards and gives themselves permanent damage. All right, then we've got finally our anti-allergy medication. So these are things that cell stabilizers, mast cell stabilizers. Mast cells release histamine. So there's a wide variety of medications. They all have weird names. We'll see some of them. But sodium chromoglycate is one example. It's sold as this Opticrom solution. And this is an antihistamine drug. So it stabilizes mast cells. It blocks histamine receptors so that histamine is not released and we don't get the inflammatory cascade. So we reduce redness, swelling, irritation. These are given as eye drops and they're sold for allergies. So like vertical conjunctivitis means inflammation of the conjunctiva in the springtime, so seasonal allergies. And these kind of sting, so they work really well. They stabilize mast cells, but these allergy medications, they do sting quite a bit. And if there are contact lenses in, they can cause damage to them. So it's important that individuals remove their lenses when they put those in and wear their glasses as long as they can, because contacts will also irritate the eye a little bit more and can exacerbate the inflammation caused by the allergies that are causing the swelling and redness. So these medications, again, they're mast cell stabilizers. So ketofen fumarate is another one, ketofen fumarate, and then we had our Opticrom. So these are drops. They stabilize mast cells. They decrease histamine release and get rid of that itchiness that you get with allergies and inflammation. Okay, then we have our artificial tears. So with aging, with glaucoma, with certain eye conditions, with cataracts, with again, aging is one of the biggest ones, or damage due to radiation at different glands in the eyes, you can get a reduction in the actual production of tears. So there's some substances that increase tear production, like tacrolimus increases tear production. And there's also your glucocorticoids, which can be given in drops sometimes along with tacrolimus, to stimulate tear production. They don't always work awesome. Another side effect of glucocorticoids in general, not only do they thin connective tissues, but they cause immunosuppression. And don't forget the eye, there's a lot of connective tissue there, so it can actually thin the layers of the eye, making it more liable to be damaged. So things like Lacrolube, they're these thick, viscid substances, and they are made out of this kind of wax. So paraffin, you might have heard of like a paraffin hand cast, like some candles are made out of paraffin. So it's a thick, viscid substance that's waxy. So you put these in, and they're physical artificial tears. They're meant to last for a couple of hours to provide artificial tears. So they're substituting tears. They're not like tacrolimus and the glucocorticoids, which might stimulate tear production. They physically are going to substitute tears. So these are used for dry, itchy eyes. These are another thing you don't want to mix with contacts. Wax in contacts, they don't work out. You should definitely take the contacts out before putting waxy substances in the eyes. And the worst thing that seems to happen with these paraffin drops is that we get local irritation around the eye. All right, so I talked about all these different eye drops that do all these things like help glaucoma, decrease pressure, change pupil size, stop allergies, stop the cornea from being worn down. And they're all really great. And the last one that we'll talk about, it's also kind of great. Its job, though, is to get the red out. Tetrahydrozoline is Visine. And if you've ever seen a Visine commercial before, their tagline is to get the red out. And they're sold that way. They don't make any bones about it. Redness reliever, red eye comfort. So why I'm mentioning Visine is if somebody is at the store, if you were sending a patient to the store, if you go to the store and you have allergies and you want to stop your eyes from being inflamed, being irritated, and you pick up Visine, the only thing that tetrahydrozoline does is constrict blood vessels. That's it. It doesn't affect histamine. It doesn't affect tears. It doesn't do anything except constrict blood vessels. So it makes red eyes or pink eyes appear white. That's all that it does. It doesn't mean it's bad. It does exactly what it's supposed to. It constricts blood vessels to remove the redness in the eye. However, it does not have any effect on the intracellular stuff happening that causes that initial inflammation and irritation. And that, my friends, is the end of eye medications. I hope you learned something. Don't touch your eyes. Don't put anything in there. And always take out your contacts before you shove something in your eyeball. All right, stay smart.